Roll that again. It is so big like this. Let me set up the system correctly first. And it should be okay now. Okay. Hello, hello. Testing, testing. Hello, hello. Hello, hello. Testing, testing. Hello, hello. Testing. Do you hear me? Do you hear me? Testing. Do you hear me? Testing. Okay, good. Okay. Sorry for let's see. Last time we had now chapter 3 talk about fluid. So hemodynamics. So talk about edema. So excess fluid in the interstitial space, which is extracellular fluid. This is outside the vessel. Types of edema, non-pitting edema, increase the vessel permeability with pus in the interstitial space. So pus is exudates. Lymphatic fluid is another type of non-pitting edema. Blockage of lymphatics leads to lymphatic fluid in the interstitial space, surface early, but eventually becomes non-pitting. Exudates and lymphatic fluids does not pit. So non-pitting edema increase the vessel permeability with pus in the interstitial space. So pus stands for exudate. Lymphatic fluid is another type of non-pitting edema. Blockage of lymphatics leads to lymphatic fluids in interstitial space. Pits early, but eventually become non-pitting. Exudates and lymphatic fluid does not pit. So exudate and lymphatic fluid does not pit, which is non-pitting edema. Now talk about pitting edema, which is transudate. Transudate with the right heart failure, such swelling of the lower extremities, fluid in the interstitial space. Transudate the pit. So there are three things that cause edema: exudate, lymphedema, and transudate. and transudates are the only one have a pitting edema. So pitting edema transudates are right heart failure, swelling of the lower extremities, so fluid in the interstitial space. So transudate which is the spit. So only one type which is transudate is a pitting edema. The other two types which is exudates and lymphedema, which is that's not pit. Now transudate and pitting edema. Transudate deals with startling force. So what keeps fluid in our blood vessels? Albumin. And this is called oncotic pressure. 80% of our oncotic pressure is related to serum albumin levels. Anytime there is hypoalbuminemia, then we will have a leak of transsolute protein less than 3%. So leaking to interstitial space via capillary and venues and cause pitting edema. If protein less than 3 gram per deciliter, so then the fluid will leak to interstitial space. Leaking of transudate also hypoalbuminemia, hypoprotein less than 3 grams per deciliter, the leaking into interstitial space via capillaries and venues, pitting edema. Capillary and venues. So normally hydrostatic pressure, oncotic pressure, which is albumin. So normally hydrostatic pressure is trying to push fluid out. Oncotic which keep in, hydrostatic push out. So therefore in the normal portion, oncotic pressure is winning. Therefore decrease oncotic pressure and increase in hydrostatic pressure will lead to transudate. So decrease oncotic pressure, so it's reduce the thing mà hold the fluid in the lumen in the cell. So then that's why uh, the fluid escape and get into interstitial space. Or if mà increase hydrostatic pressure, which is too much water in blood volume, so also force the water out to interstitial space. Called this transudate. Only one type which is transudate, which is called pitting edema. Albumin is made in the liver. With chronic liver disease, cirrhosis, have a decreased albumin level. Can you vomit it out? No. So can grab it out, malabsorption syndrome, or can pee it out, nephrotic syndrome. So can come off our skin, which is third degree burns because losing plasma. Another possibility of low protein cow, low intake is seen in the case which you wash your core. It has a fatty liver and decreased protein intake, leading to low albumin level. Example, patient with myocardial infarction 24 hours ago, and he died and they have a fluid come out. It's a transudate because increased hydrostatic pressure with left heart failure due to myocardial infarction. So things back up into the lungs because the cardiac output decrease and EDV increase and diastolic volume increase and pressure on the left ventricles increase and the pressure is specific into the left atrium to the pulmonary vein 8 millimeter. So pressure keeps backing up and the hydrostatic pressure in the lung approaches the oncotic pressure 25 milliliter and the translate starts leaking into the interstitial space, so which leads to activation of the J receptor, so which will cause a dyspnea. Leads to full blown in alveolar and pulmonary edema, which is what this is. Venom from bee sting on arms leads to exudate due to anaphylactic reaction. Phase well with histamine B in the propagator and type 1 hypersensitivity reaction causing tissue swelling. Treatment with the airway 1 over 1000 aqueous epinephrine subcutaneously. Cirrhosis of liver with swelling of the legs. Translate mechanism decrease oncotic pressure because it cannot synthesize albumin and increase hydrostatic pressure because of portal hypertension. There is cirrhosis of the liver and the portal vein empties into the liver. In this case, it cannot, and there is increased hydrostatic pressure pushing the fluid out into the peripheral cavities. So there are two mechanisms for ascites. So pitting edema in less, decrease in oncotic pressure. Patient with independent pitting edema, patient has a right heart failure and therefore increase the hydrostatic pressure with right heart failure. And blood behind the failed right heart is a venous system. Cirrhosis of liver is due to decrease in oncotic pressure. Modified radical mastectomy of the breast with non-pitting edema. So this is a lymphedema, so that's a non-pitting. Other causes: W. pancreatic, lymphogranuloma, venereum, subtype subchlamydia trachomatis, scarring tissue, and lymphatics, leading to lymphedema and scrotum lymphatic inflammation, carcinoma of breast, powder orange of the breast, this with dermal lymphatics plus with the tumor. So it leads to dimpling and looks like the surface of orange. Most common cause lymphedema, post-radical mastectomy, can also run risk of lymphangiosarcoma. Renal physio, so ECF over ICF, extracellular fluid over intracellular fluid. Extracellular fluid, 1/3. So equal extracellular fluid of two compartments. Vascular movement, which is 1/3, and interstitial, which is 2/3. And intracellular fluid, which is the rest of 2/3 of the body. Intracellular fluid compartment. Okay. Example, how many liters of isotonic saline do you have to infuse to get 1 liter into the plasma? 3 liters. Two over 3 over 1/3 relationship. 2 liters in interstitial space and 1 liter would go to vascular space. Plasma would be 1. 1/3, 1/3 y, 2/3 y cộng cho 2/3 divided equal 1/3 y, 2/3 I. See the body fluid will be equal, which is 1/3 E plus 2/3 I. And then E này equal 1/3 E plus 2/3 I. E thì includes 1/3 vascular, which is plasma, plus 2/3 interstitial space, IN, INT. Now, which is plasma equal 1, thì then how to find if we give plasma equal 1, calculate this not clear. To get 1 liter into the plasma, 3 liter, the ratio 2/3 over 1/3 relationship, 2 liter interstitial space. Okay. So we know which is in plasma 1, the interstitial, which is 2. 1 plus 2 equals 3. Right? What time now? Osmolarity. So 2 into 1 liter will go to vascular space. So if you 1 go there, the 2 go there, because the ratio to the basically brace with intravascular compartment. Osmolarity measure of solutes in the fluid due to 3 things: sodium, glucose, and BUN. So urea cycle is located in the liver, partly in the cytosol and partly in the mitochondria. Usually multiply sodium times 2 because 1 sodium and 1 chloride. So sodium is 135 to 140 times that by 2. So then that equal, which is 280. So for glucose normal is 100 divide that by 18. So let's say it's roughly 5. So that not contribute much. BUN located in the liver. Partial cycle is in the cytosol part of it is mitochondria. The urea comes from ammonia. So thus ammonia is gotten rid of by urea because the end product of the urea cycle is urea. The normal is about 12, divide that by 3, so we have 4. Therefore, in the normal portion, sodium is controlling the plasma osmolarity. To measure serum osmolarity, double the serum sodium and add 10. So the osmolarity is talk about osmosis. Two of these three are limited to the extracellular fluid compartment. One can equilibrate between ECF and ICF across the cell membranes. So urea, therefore, with the increased urea, it can equilibrate equally on both sides till it will be equal on both sides. This is due to osmosis because sodium and glucose are limited to the ECF compartment. Then changes in its concentration will result in the movement of water from low to high concentration. Opposite of diffusion is in lungs, 100 millimeter mercury in alveoli of oxygen, and returning from the tissue is 40 millimeter mercury PO2, 100 versus 40, which is bigger. 100 is bigger, so that diffusion. So oxygen moves through into space into plasma to increase the sodium to about 95 millimeter mercury hemoglobin. I don't know, mercury hemoglobin. Therefore, in diffusion, it goes from high to low, while in osmosis, it goes from low to high concentration. Example, in the case with hyponatremia, water goes from ECF into the ICF because the lower part is in the ECF, hence hyponatremia. Water goes into the ICF and therefore is expanded by osmosis. Now make believe that the brain is single cells. Will we see cerebral edema and mental status abnormalities via law of osmosis? The intracellular compartment of all the cells in the brain would be expanded. Example, hyponatremia, water goes up from the ICF into the ECF, therefore the ICF will be contracted. So in the brain, it will lead to contracted cells, therefore mental status abnormalities. Therefore, with hypo and hyponatremia, we get mental status abnormalities of the brain. Example, DKA have a 1000 large amount blood sugar. Remember that both sodium and glucose are limited to the ECF compartment. So you would think that glucose is in the ICF, but it's not. You think that since glycolysis occurs in cytosol, therefore glucose in the ICF, again is not. Because in order to get into the cell, intracellular, glucose must bind to phosphorus. Generated G6P, which is metabolized, is the same with the fructose and galactose, so which were also metabolized immediately. Therefore, there is no glucose, fructose, or galactose per se intracellularly. So with hyperglycemia, there is high glucose in ECF. So water will move from ICF to ECF. Therefore, the serum sodium concentration will go down. This is called dilutional hyponatremia, which is what happens to the serum sodium with hypoglycemia. Therefore, the two things that control water in the ECF are sodium glucose. But in a normal situation, sodium control. So urea does not control water movements because it's permeable, so it can get through both compartments to have equal concentrations on both sides. So tonicity, isotonic states, hypotonic states, and hypertonic states. We have all different types of saline, isotonic saline, hypotonic saline, and half normal saline, quarter normal saline, 5% dextrose in water. So in hypotonic saline, which is 3%, 5%, normal saline is 0.9%. We are referring to normal tonicity of the plasma, which is controlled by the serum. These are the three types of tonicity: iso, hypo, hyper. So serum sodium is a reflection of total body sodium divided by the total body, which is water. For example, hyponatremia is not just caused by increased total body sodium. It can also be caused by decreases total body water in the water in a normal water body. So sodium. So therefore, there is an increase in sodium. Uh, well, 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 so, for example, hypernatremia is not just caused by increased total body sodium. It can also be caused by decreased total body water in a normal total body sodium. Therefore, there is an increased sodium concentration. This is really a ratio of total body sodium to total body water to determine serum sodium. Just look at the serum levels with different fluid abnormalities can lose again the certain tonicity of fluid. So isotonic loss of fluid. Look at ratio of the total body sodium and water. In this case, you are losing equal amounts of water and sodium, hence isotonic. So this of course isotonic. This fluid is mainly lost from the ECF. The serum sodium concentration is normal when losing isotonic fluid. ECF would look concentration. The serum concentration is normal when losing isotonic fluid. ECF would look contracted. There would be no osmotic gradient moving into or out the ECF clinical conditions where there is isotonic loss of fluid, hemorrhage, and diarrhea. If we have an isotonic gain, we have an equal increase in the salt and water. Someone getting too much isotonic saline, normal serum sodium, excess isotonic sodium would be in the ECF and there would be no osmotic gradient for water movement. Hypotonic solutions, by definition, it means hyponatremia. Hypoglycemia will not produce a hypotonic condition. Most common cause of low osmolarity in plasma is hyponatremia. How lose more salt than water, therefore serum sodium would be decreased. If losing more salt than water, kidney is probably the location of why it is happening. Main place to deal with sodium, either to get it off it or to get it back, is in kidney, especially when dealing with the diuretic. So furosemide or ICTZ, so the tonicity solution you lose in your urine is hypertonic. So that's how you end up with the hyponatremia with the hypotonic condition. ECF concentration is low with the hyponatremia. Therefore, the water will move into the ICF compartment osmosis. Remember, low to high. Example, if you gain pure water and no salt, you have really lowered your serum sodium. Most common cause, which is SI-IDH, in small cell carcinoma of the lung. You gain pure water because IDH renders the distal and the collecting tubular permeability to free water with IDH present. So we'll be reabsorbing water back into ECF compartment, diluting the serum sodium, and ECF-ICF will be expanded. The ECF is expanded due to water reabsorption, and the ICF is expanded because it has a high concentration levels. Its level was not diluted. It can lead to mental status abnormalities. Therefore, the more water you drink, the lower your sodium levels will be. The treatment is by restricting water. Don't want to restrict sodium because the sodium level is normal. When IDS is present, you will concentrate your urine because taking free water out of the urine with option 88. So lose free when urine. And for with the SIADS, so water stay in the body, goes into the ECF compartment, and when move into the ICF compartment via osmosis, the lowest serum sodium will be in SIADH. On the board, when serum sodium is less than 120, the answer always SIADH. So example, patient with SIDF, not smoker, so therefore not a small cell carcinoma. Therefore, look at drugs. She was on chlorphropramide oral sulfonylurea, produce SIDH. So example, again, more water and salt, but more water than salt, leading to hyponatremia. So this the pit-in edema stage, right heart failure, cirrhosis of the liver, when total body sodium is when total body sodium is increased, it always produces pit-in edema. What component is the total body sodium is ECF? What is the biggest ECF component? Interstitial component. Therefore, increase in total body sodium will lead to expansion interstitial compartment of the ECF. Water will follow the show, therefore you get expansion via transudate and pit-in edema, sit in dry heart failure and cirrhosis. Example, hypotonic loss of salt from the uretic leads to hyponatremia. Example, SIDX gaining a lot of water leads to hyponatremia. Example, gaining more water than salt when moderate shortness into hyponatremia because of edema. Okay, maybe for now for today.